अब मैं जिनको इंट्रोड्यूस करा रही हूँ, डॉक्टर सोमिया इक़्तिदार. I'm thankful to you, Somia Iqtadar, for joining us all the way from Hyderabad. She has come from Lahore actually, and they had been to Hyderabad. रात को 1:30 बजे हैदराबाद से आई और फिर सुबह यहाँ हमारे पास आ गई. तो thank you very much for taking so much of trouble. And I'm also thankful to Dr. Nabil Akbar, her husband, who has accompanied her. And thank you, Dr. Akbar, for taking care of Somia and us. So Somia is Associate Professor of Medicine, King Edward Medical University, Lahore, and she is also the Secretary General of Pakistan Society of Internal Medicine. ये पाकिस्तान सोसाइटी ऑफ इंटरनल मेडिसिन बहुत अभी छोटी उम्र में है, बट शी इज़ द फाउंडर ऑफ दिस सोसाइटी. और मेरा ख्याल है कि इस सोसाइटी ने बहुत सारा काम किया है टुवर्ड्स एजुकेशन, टुवर्ड्स क्लिनिकल केयर ऑफ पेशेंट्स. एंड सोमिया का तो इंट्रोडक्शन इतना बड़ा है कि मैं करूं तो फिर इनका लेक्चर की टाइम नहीं रहेगा. तो शी इज़ ऑल्सो एसोसिएटेड विद कुमार. शी हैज़ कॉन्ट्रीब्यूटेड कुमार एंड क्लर्क टेक्स्ट बुक ऑफ medicine on dengue, Ebola and Congo. And she is also editor and advisory board on McMaster textbook of medicine. And she has written a handbook on dengue and guidelines on dengue in pregnancy as well. अभी lately हमने एक program attend किया था लाहौर में about women health initiative, and that was a real good program about women leadership, which Dr. Somia has initiated, and she is advisory board of Women in Global Health Pakistan chapter. So I would invite Dr. Somia Iqtadar, and it would be a treat to listen to her. Thank you, Somia.
Thank you very much, Dr. Shabeen, for your very kind introduction. Ladies and gentlemen, it's always great to be here in Karachi. और Professor Shabeen, Professor Zaman, Professor Basit हमेशा बुलाते हैं, और मुझे याद आती है हमेशा Professor समद शेरा की. अभी उनकी मिसेस से मुलाकात हुई तो उन्होंने कहा कि मेरी आपसे मुलाकात नहीं है. मैंने कहा कि मेरी आपसे वैसे मुलाकात नहीं है, लेकिन थ्रू प्रोफेसर समद शेरा मेरी आपसे बहुत ज़्यादा मुलाकात है. सो आई ऑलवेज़ रिमेंबर हिम व्हेन एवर आई एम गिविंग अ टॉक स्पेशली ऑन डायबिटीज़. तो मुझे बहुत याद आता है, और आज का लेक्चर भी मैं उन्हीं को डेडिकेट कर रही हूँ. सो आई कम फ्रॉम लाहौर एंड आई वर्क एट किंग एडवर्ड मेडिकल यूनिवर्सिटी. एंड द टॉपिक यहाँ चलेगा, यहाँ चलेगा सामने. Okay, so I will be taking you through a journey of hyperglycemia management in pregnancy. And just to give you an overview, hyperglycemia in pregnancy is the term that we use now instead of gestational diabetes alone, which is the elevated blood glucose levels during gestation. And it can be gestational diabetes, which develops during pregnancy and resolves after the childbirth, or it could be pre-existing diabetes, which is that women already have diagnosed diabetes and then they enter into the phase of pregnancy. It is commonly affecting our population globally as well as nationally. Globally, 6 to 9% of pregnancies, they encounter this hyperglycemia in pregnancy. And there are certain risk factors which are involved and they contribute to this condition, which include the advanced maternal age, if you have a family history of diabetes, if there has been previously history of gestational diabetes, and obesity, which remains the hallmark of causing hyperglycemia in most of our patients. Okay, so hyperglycemia in pregnancy can have effects both on mother and the fetus. So it is important to screen early, because early detection can help us in effective management at an early stage. On the maternal side, it can increase the risk of preeclampsia. There's increased likelihood of cesarean section, and there's greater susceptibility of developing type 2 diabetes in the later part of the life. And on the other hand, on the fetal side, we all know that these children who are born to babies, who are born to mothers with gestational diabetes or hyperglycemia in pregnancy, they are large size baby, large for birth weight, and there are also chances of neonatal hypoglycemia. But also, there is increased risk of childhood obesity and later in the life of developing type 2 diabetes. So abhi hum baat kar rahe the primordial prevention ki. So I think this is the right time when you need to identify and you need to know that where does the actual risk start from. So the actual risk starts from actually, if we go back into the thrifty phenotype hypothesis, which is the long-term adaptations in response to in utero environment. So when there is fetal malnutrition because there is low caloric intrauterine environment, then there are permanent changes in your chromatin structure and gene expression, which lead to altered insulin secretion and resistance, because then they want to have an efficient energy utilization. And this then results in predisposition to insulin dysregulation, which thereby leads to obesity and type 2 diabetes mellitus. So this is the basic pathophysiology which is actually responsible for development of these problems. And if we look at the data from around the world, this is a study about 2,331,618 patients across different countries they were studied. Among them, there were Southeast Asian people, there were Chinese people, and then the general population. And when they compared, you will be surprised to know that the highest incidence of gestational diabetes and childhood obesity all across this population was seen in the Southeast Asian group. So genetically, we are more predisposed to develop this hyperglycemia in pregnancy, which subsequently leads to childhood obesity. And what are the consequences of this? We also need to know if we are actually priming our children. So once these children who are developing in the womb of a gestational diabetes mellitus female, then they are, when they're exposed to this environment, they do not only have short-term complications, but also the long-term complications in the later part of their life. So in the short term, where they have chances of more premature birth or delivery complications, in the long term, they have more chances of developing obesity, cardiovascular disease, type 2 diabetes mellitus, endothelial dysfunction, and cardiovascular problems. So in utero, there are epigenetic changes, there are mitochondrial biological changes, and there are so many mechanisms which actually lead to the fetal programming of the cardiovascular disease while in utero. And when the child are born in the postnatal, there are increased adiposity, there's increased body weight, there's increased waist circumference, then there are larger size babies or macrosomia, and premature gluconeogenesis gene activation, which leads to many problems. So actually, it not only starts after the birth, it is before birth, which is translated into your later part of the life, increasing your risk of bad cardiovascular outcomes. In the adolescent also, there is an increased risk of pediatric diabetes and increased rate of cardiovascular disease in the early part of the life. And obviously, in the adulthood, babies who are born to mothers with hyperglycemia in pregnancy, they have not only insulin resistance and hyperglycemia, but they commonly suffer also from metabolic syndrome, obesity, and type 2 diabetes mellitus, along with the fatty liver disease and cardiovascular disease. So there is an integrational perpetuation of cardiovascular disease, and that is why it is very important to start with the primordial prevention if we want to really, cut the tire right at the beginning at the grassroots level. So there are other challenges as well. Not only in hyperglycemia in pregnancy, there are challenges with diagnosis and screening, but the major problem, which Dr. Shabeen very rightly pointed out, is the resource-limited setting in which we all perform. So the resource-limited settings are not only in our part of the world, they are worldwide. But there are challenges other than the cost as well. Cost remains one of the major challenges, but education and awareness, resources allocation, access to the care, adherence to the treatment, and myths and social norms, they also pose a serious threat when we are dealing these patients of hyperglycemia in pregnancy. So the question arises, when should we screen our patients? We know that the Southeast Asian population has the highest incidence of hyperglycemia in pregnancy in whole of the world. So should our screening protocols be different from the rest of the world? Should we screen our mothers earlier than the usual recommendations? And the recommendations for early blood glucose screening in pregnancy, we usually know, oh. So we know that they're usually 24 to 28 weeks we screen, but in sometimes on the first antenatal checkup, it is important that we screen our patients, especially if they are high risk. Because importance of glycemic control in pregnancy leads to so many benefits, not only for maternal health, but also for the fetal health. In the maternal health, it prevents not only complications related to the mother, but also improves the pregnancy outcomes. And in the fetal side, it prevents macrosomia, it reduces neonatal complications, and in long-term applications, as I told you, it helps in prevention of childhood obesity, which reduces the risk of type 2 diabetes in the offsprings, and improve glycemic control and optimal blood glucose control through individualized treatment plans makes better outcome of mother and fetus. And this also reduces the healthcare costs in the long term because the preventive approach leads to minimized hospitalization and obviously cuts down on the cost of complications. So the treatment of booking gestational diabetes mellitus, this is TOP-BO-GM study, you can say. It's a big study which is going on and it's still being carried out. This was a study which was done as a randomized control trial that is testing whether treating women with gestational diabetes as soon as they are diagnosed during the pregnancy improves the pregnancy outcomes. And this study is being conducted in Australia, Austria, Sweden, and India at the moment. So women who are diagnosed with GDM at their first antenatal appointment or the booking of a patient are randomized to either receive immediate treatment or to defer treatment to a time which is the actual testing time of GDM, which is 24 to 28 weeks of gestation. And treatment obviously includes the dietary advice, the lifestyle changes, the exercise, and the blood glucose monitoring. And the primary outcome of this study is that the rate of macrosomia, which is the birth of a baby weighing more than 4 kilograms at the time of delivery, and the other outcomes that were being measured included the rates of preeclampsia, cesarean section, and neonatal hypoglycemia. So the study is the first large-scale RCT to test the benefits and harms of early treatment of GDM, and the results of the study are expected to be published in 2024. But this study is an eye-opener for all of us in the Southeast Asian region, because early detection can help us prevent so many complications in the long term. So should we change our guidelines of routinely screening for GDM from 24 to 28 weeks to the first time the patient encounters a gynecologist or an obstetrician for checkup at the time of booking, so that early detection can help us manage these patients better? Coming on to the management of hyperglycemia during pregnancy, we all know the traditional ways of glycemic control in the pregnancy, which includes as a first step diet and nutritional modifications and importance of a balanced diet. So we give dietary guidelines to the patients, we tell them about carb counting, then complex carbohydrates and fiber intake recommendations are given. And then there are meal planning strategies. So Dr. Munira very rightly pointed about the regular and consistent meals, the portion control, and the importance of giving a balanced macronutrients to these patients. But we also need to know that the requirements are different for different people and the plans have to be individualized, and we need to involve the specialists for this. And the specialists, when we're talking about diet or lifestyle, is the lifestyle medicine people or a nutritionist or a dietitian. So involvement of them and education about the self-monitoring of blood glucose remains as a core competence when we are managing the patients with hyperglycemia in pregnancy. And we also need to break this myth, which is in the general public, that once you are pregnant, you are at bed rest. So this is the time that we need to educate our patients that regular physical activity and safe exercises during pregnancy actually improve the outcome of the pregnancy, and it is not the time to rest for the entire 9 months duration of pregnancy. So regular physical activity is actually helpful for glycemic control because not only it has general health benefits in your well-being because mobility increases your power and strength, but also it helps in glycemic management and your weight management, which are the two most important pillars when we talk about management of hyperglycemia. And there are safe exercises during pregnancy like aerobic exercises, prenatal yoga, strength training, and pelvic floor exercises, which actually help your patients in improving the outcome in the form of better modes of delivery and long-term less complications. So the guidelines and considerations regarding the physical activity and exercise should be in consultation with the healthcare provider, which actually tells you that what are the high-risk activities which you should avoid and which are the safer exercises that you should be doing regularly to improve your journey of hyperglycemia. And when we talk about the next step apart from diet and exercise in a traditional way, we know that we tell our patients to monitor the blood glucose levels, and traditionally the methods and tools which are used are the self-monitoring, which is either fasting or a postprandial check. And traditionally we use glucometers, as with strips and lancets we take the blood glucose, capillary blood glucose, and through portable glucometers we check the blood sugar levels. And we keep the record of this in the form of either logbooks or journals, or manually we analyze them. And then the patient brings these logbooks or these charts to the regular clinic follow-up, and the healthcare professional looks at these readings and then advises them. So this is a traditional way of managing a hyperglycemia in pregnancy. But is there anything different in this new era of medicine that we can do which can actually improve the glycemic control in pregnancy and improve the outcome of the patient? This is what I'm going to talk about in the next few slides. So this is a device, I'm sure all of you know about it. This is the continuous glucose monitoring system. The continuous glucose monitoring system is actually, yeah, but text nahi aa rahe hain aapke, sare missing hai. Nahi aa rahe na? Aapke paas wahan aa rahe hain? इसलिए मैंने कहा चेक कर ले. Okay, so continuous glucose monitoring system is the system which gives you a trend or time in range values of your glucose. And this is a better tool because it is monitoring your blood glucose throughout your day. And this has the convenience that you do not have to prick the patient repeatedly, and you do not have to maintain a manual record of the patients. It continuously monitors your glucose and at the same time delivers the insulin according to the blood sugar levels, also giving you the alarms of highs and lows and telling you that how your sugar profile is throughout the day. So this is the data which comes in front of us. Many of the, I'm not sure if many of the gynecologists use it, but many of the endocrinology practice people, they use CGMs for managing these patients, both for type 1 diabetes and type 2 diabetes mellitus patients. And you would see that you will see these kinds of graph, and you will see the target range is in green. So if most of your readings, which is required that about 75% of your readings should be in the target range, they are in the target range, you have good glycemic control. But if there are too many bizarre readings, too many highs and lows, this is something that we do not desire. So the time in range is the new concept in management of type 1 and type 2 diabetes, in which we say that your goal is that your 70% of your readings should be in your target range, and there is a margin that they can have less than 25% in the high and less than 5% in the low. But if you are out of this range, so very highs and very lows and out of the range for most of the time, this is a big no, and this is not something that we desire. So this gives you an overall picture of your patient's blood glucose profile throughout the day, and obviously it helps us in making better decision for the patient because we exactly know that with what type of food, what is the glycemic spike and how do we address it via delivery of insulin or anything. So these newer devices, I know they are costly and not very easily available, but these are the new devices which improve the outcome of these patients. This is the ambulatory glucose profile, which is a summary of glucose values from the report period with the median and other percentiles, and it shows all the readings which are done multiple times in a single day. And this shows you that how many of your readings are in the target range and which are out of target. making you take better decisions for these patients. And daily profiles represent from one midnight period to the other midnight. It gives you an idea about the peaks and troughs and the targets, and these can be better addressed if you show these graphs or these ambulatory glucose profiles to your healthcare professional. They tell you that there you are going wrong. This is the meal which you should not be taking because this led to a spike in your level. This was the activity level which was lacking over there, which could help you bring down your glucose in the target range. So this gives you an overall excellent profile. But a shorter form of this, if that is not affordable by most of the people, are these devices which are now available in Pakistan also with the name of Libre. So there are 3 models of Libre which are available worldwide, Libre 1, 2, and 3. 1 is available in Pakistan, 2 is in Middle East, 3 is in UK, and 3 actually works as a CGM, and it can be attached to your mobile device. You do not have to prick the patients. A sensor is placed on your forearm. You just connect it via Bluetooth, and on your mobile app, you just get the reading. So you don't have to check multiple times in a day. And it, just like CGM, the Libre, it forms the pattern and gives you time in range and glucose profile of the patient. And then there are insulin pumps. And insulin pumps, again, phir aapka text nahi aa raha. So insulin pumps, they deliver the insulin according to the blood glucose levels, and these are closed loop system where they check the blood sugar levels, they calculate the amount of dose which is required for the insulin, and then they are given to these patients. So these are some of the newer devices in which there is a continuous glucose sensor and there is an insulin pump attached to the patient which automatically, regulates the blood sugar levels, and especially it is very helpful during pregnancy. And then there are simple mobile applications for tracking nutrition and exercise during pregnancy. I was very glad to hear from Professor Jahan Ara that they're also developing an app in their institution, I think by the postgraduate residents or students as a part of research grant from NIH, in which they're developing an app for checking the, tracking the record of the patient during the entire pregnancy period. And I think in today's era of artificial intelligence and modern medicine, this is the type of research things that we should be doing, and they should not be copied from the West, but they should be, homegrown. So there are multiple mobile applications for tracking nutrition, blood sugar level, exercise plans, delivery outcome improvements, which are available on the net. But you can all see, so there are nutrition tracking apps in which you have food diary functionality or nutritional analysis. There are exercise monitoring apps which tell you how much activity you are doing in the day. They can revise customized workouts. And then there are pregnancy-specific features which gives you gestational age tracking, and weekly progress updates are also entered in that. And this health data integration with the wearables and blood glucose monitoring integration can improve really the journey of hyperglycemia in pregnancy in our pregnant population. Also, there are a lot of educational resources available on net, on the mobile applications in the form of informational contents and push notifications about diet, about exercise, about management of hyperglycemia during the pregnancy. And there are also social support in community. Dr. Munira very rightly pointed out that we need to improve our mental health, and a major part of the mental health comes from the social support and the network of the counselors. So in Western countries, we do see that there are groups which help build each other, emotionally and support each other, but such community forums and experts' guidance is somehow lacking in our setup. And I think it's about time that we develop such forums for improving the outcome of our patients. These are some of the apps which are available free on the internet, which you can advise your patients, MyFitnessPal, Chronometer, and MySugar, which they can download in their applications in their phones, and they can use them as they embark on their journey of hyperglycemia in pregnancy. So what are the advantages of the new techniques? So the continuous monitoring or precision gives us a real-time picture of the patient, and these continuous trend analysis not only increase the precision in the insulin delivery, but also reduce the variability in the glycemic levels. And this leads to minimization of swings and optimized glycemic control, which is translated into better outcome of the patients. Then there is enhanced patient engagement. When you involve your patients in such newer things, they try to learn these things. They feel empowered through this information, and then they give you a personalized feedback about these applications used. So they feel more trusted, they are more collaborative with the healthcare professional, and also the healthcare professional who are managing these patients with the help of these devices, they have the edge of having remote monitoring of these patients all the time. So even if they cannot follow up these patients in clinic, in person, on a very regular interval, through remote monitoring, they can make decisions by looking at the data, by looking at the trends, by looking at the hyperglycemic ambulatory glucose profile, and then suggest your patient about the decisions that they can take to improve it. Also, this leads to enhanced patient compliance as well, because patient feels that there is reduced injection frequency, there is less intensive monitoring because a person is already having this in place and continuously being monitored. So they do not have to prick again and again, they do not have to go and visit the doctor again and again. So it improves their compliance with the treatment as well. It improves the user experience as well, because it has enhanced convenience and it becomes a part of their daily life, and it integrates with all the activities that the patient is doing during the day, and it gives a personalized and an individualized care touch to the patient, because they have their tailored treatment plans and they feel empowered. This also gives us a real-time feedback and education. So if a patient comes to me saying that I had a hypoglycemic episode yesterday, what am I going to do now? But if that alarms of hypoglycemia just rings on my bell, at that moment I can timely take a decision and save the life of the patient. So immediate insights can help improve the outcome in emergency situations. And the remote monitoring and support not only improves the outcome, but it makes the decisions for the healthcare providers to be taken conveniently, and this intervention is then based on real-time data which we are collecting from our patients. So the optimized glycemic control and reduction in maternal outcomes, along with fetal and neonatal benefits of decreasing the risk of macrosomia and neonatal hypoglycemia, are some of the features of these newer technologies which help us safely go through and navigate through our journey in hyperglycemia. It also improves the pregnancy planning and management. We can actually use these newer technologies as a part of preconception care and early detection of issues even before the start of the journey of hyperglycemia in pregnancy, and counsel our patient and educate our patients about the preconceptional measures that they need to take before planning their pregnancy. And in the neonatal health, if we improve the outcome with the help of good management of our glycemic control and continuous monitoring and minimizing the risks of hyper and hyperglycemia, it is translated into risk of other diseases as well, which the neonate can suffer, like respiratory distress syndrome or neonatal morbidity due to other causes, thereby improving the outcome of the patients. So let me say by saying that it's not just these 9 months of time that you need to monitor these patients, but it's actually a life course strategy. And this life course strategy starts with the maternal and child health. And we say that the first 1,000 days of your life, what you do and eat in first 1,000 days makes a difference for the rest of your life. So it is very important to invest not only in primordial prevention, but also in the immediate postnatal period, which determines the fate of this outcome. This is one small case study just to give you an idea how these technologies work. This is a patient who's Sarah Ahmed, age 32. She's a type 1 diabetic. Gestational age is 28 weeks, and she has a history of type 1 diabetes mellitus. And she was discovered as she's pregnant now, and she knows that she's type 1 diabetic, and she knows that there has to be stringent glycemic control during pregnancy. So the physician who's providing healthcare to this young lady and the patient herself, they embark on a comprehensive care plan. So they start with the continuous glucose monitoring system. She opted for CGM, which allows her real-time monitoring of the blood glucose levels, and it helps her identify patterns and which enabled her to adjust her insulin according to the patterns which CGM provided. And the insulin pump therapy She was actually taking multiple injections before pregnancy, but she switched to a pump, and it allowed a continuous basal insulin and on-demand bolus doses, and which this pattern mimics the natural pattern of the insulin secretion in the body, thereby making it very convenient for the patient. So this integrated care model, which is a collaborative care including the patient herself, the gynecologist or the obstetrician, and we can also involve an endocrinologist or a diabetic educator. It not only omits the need for very frequent check-ins, but through a telehealth portal, you can just continuously monitor your patient throughout this journey, making it more useful both for the mother and the fetus. And the impact on the maternal well-being was that not only Sarah felt very reassured and she had reduced anxiety and stress because she knew that she was taken care of throughout. So this also translated into the better outcome and better health of Sarah during the entire journey. And this real-time data from CGM provided a reassurance and fostering a sense of control over her disease, making her more empowered. It also, with the use of insulin pump therapy, Sarah's daily routine, she adjusted accordingly, offering flexibility in reducing the burden of frequent injections because she doesn't have to adjust her insulins because the insulin pump takes care of it. And this integrated care ensured a consistent support and addressed her concerns very promptly. On the other side, in the fetal side of the pregnancy, the stable glucose levels, they contribute to minimizing the risk of fetal complications and optimal fetal growth. So because of a good glycemic control, there is optimal fetal growth without signs of macrosomia, and regular monitoring ensured that the insulins are adjusted and aligned with the baby's developmental needs, making this a very, very useful combination. So Sarah successfully reached 28 weeks of gestation without any major complications. Her regular ultrasounds indicated a healthy, normal developing fetus, and ongoing glycemic control set the stage of a well-planned birth, minimizing the likelihood of emergency interventions because she's being regularly monitored continuously throughout her journey, and a collaborative care allowed for the creation of a birth plan aligning with the Sarah's preferences. So I would end my talk here by saying that technology doesn't represent the future of medicine. It is the current state of medicine. I know that we have cost issues and it is a huge burden, but as a medical doctor, it is our duty to ask the patient and make them aware of the newer technologies. You cannot assume that this patient cannot afford the treatment. Maybe they want to opt this treatment by sacrificing something which is very superficial and invest in their health. So as a healthcare professional, it's our duty to tell them the benefits, to tell them the cost, discuss, and then embark on the journey of management of that patient care plan as a shared decision between a healthcare professional and a patient who is coming to that doctor. Many a times, we just assume and we do not tell our patients because we think that this is not practical or applicable in our society. But this needs to be discussed because the cost which is burdened at this point in time might cut down on a cost of long-term complications and improving the outcome of these patients. So thank you very much for your patient listening. I would take this opportunity just to, 2 days back, Dr. Shabeen was with us in Governor House. Dr. Basit and Dr. Zaman also joined us. So there was a ceremony in the Governor House where they were acknowledged for their extraordinary contribution, for their continuous service to the field of medicine in Pakistan for the last so many decades, I must say now. And this is a wonderful initiative of writing textbooks of medicine. I think this is the time that medical professionals from Pakistan should contribute to research and publications and guideline development and textbooks of medicine so that the world knows that we are nowhere behind the rest of the world. I take this opportunity to invite all of you to our annual international conference, which is going to be held in Islamabad